Hi, and welcome to the Embouchure Project podcast, where we bring together the finest minds in the world to help understand the complex system that is the embouchure. The Embouchure Project represents a network of neurologists, scientists, physical therapists, psychologists, and pedagogues. The goal is to help define what a healthy embouchure is, what we can do to optimize the embouchure, and to deal with problems as they arise. A lot of our time will be devoted to embouchure dysfunction, from minor annoyances to debilitating forms of dystonia. We hope that all players, teachers and medical professionals will find this to be a rich resource. My name is Frankie Lacerdo. I'm a horn player with the West Australian Symphony Orchestra, founder of Brass Rehab, and on faculty as a teacher at the University of Western Australia. Thank you for joining us. We hope you find this to be informative and helpful. The Embouchure Project would like to thank the Australian Society of Performing Arts Healthcare and the Glenn Gould School for their support. Today we welcome Dr. Eckart Altenmüller, one of the world's leading experts in the field of neurophysiology and neuropsychology of musicians. He holds a master's degree in classical flute and an MD and PhD in neurology and neurophysiology. Since 1994, he's been chair and director of the Institute of Music Physiology and Musicians Medicine in Hannover, Germany. He continues research into the neurobiology of emotions and into movement disorders in musicians, as well as motor, auditory, and sensory learning. His work has been vital to the understanding of embouchure dysfunction, and we're honoured to have him on the podcast. Let's meet him now. Well, welcome back to the Embouchure Project podcast. My name is Frankie Lacerdo, and I'm very excited to have a very special guest this week, Dr. Eckart Altenmüller. Welcome.
Yes. Hello, Frankie. Hello.
Did I say your name right? Altenmüller.
Yeah, it's fine. It's a very good.
It's good.
The German umlaut Ü is very
Yeah.
difficult, and you did very well.
I'll practice. Yeah.
Yeah.
So I'd love for you to just tell our listeners just a bit about yourself, what you do day to day, and what you've done in your career, and what you're up to at the moment.
Yeah, that's. I'm for my training here. I'm on one side. I'm a neurologist, and I'm also a flute player. I'm trained in Paris and in Freiburg for flute, and I'm now working at the University for Music, Drama, and Media in Hannover, Germany. And I have I'm directing a large institute, and I have three things to do. So first of all, we have a prevention program, and we teach our music students to stay healthy in their profession. And this includes not only piano students or violin students, but also singers and, of course, brass players and woodwind players. And that is my core teaching subjects. So prevention and healthy habits to stay lifelong happy, healthy musician. My second task is I have a clinic, and in this clinic I see musicians from all over Central Europe, mostly Germany, Italy, the Benelux countries, and also Scandinavia and England. And they are suffering from severe problems, professional problem linked to making music. So I see indeed every week some patients suffering from embouchure dystonia, some patients suffering from hand dystonia, but also chronic pain, and also now more frequently in the last 5 years, anxiety problems. And my third task is to do research into the effects of music on the brain in both in healthy people and in people having neurological problems. So we have a very large project in the moment going on the effects of piano practice on the elderly. So we had a group of 140 seniors which were learning to play the piano at age 70, and we are observing them, how they develop, how the brain is connected, and also how life quality, depression scores, etc., develop in the last 3 years.
Yeah, well, I thought you meant the effects on the neighbors of piano players.
Yeah, yeah, that's another
But,
point.
but-
I
yeah, no,
have to
that
say,
sounds, yeah.
Frankie, we indeed we organized pianos for all these 140 subjects, and we indeed did electronic pianos with
Yeah,
headphones. So in case the neighbors were complaining,
yeah,
we
yeah,
could.
yeah. How fascinating! What incredible stuff you're doing. So, uh, you've been studying the embouchure for a lot.
Yes.
Just coming back to the embouchure, how did this very niche part of musicians' health become of interest to you?
This is an interesting point. I'm trained as a neurologist, and I had in my career, I was 9 years in a university clinic for general neurology.
Hmm.
And at that time, that was from 85 to 94, nobody knew anything about dystonia and musicians' dystonia. I remember
Mm,
my first patients in 85 were misdiagnosed by myself. And so I realized there is something strange with this problem. There is nothing to see. Control is somehow difficult. And
mm,
we did all these brain scans and all these things, and nothing came out. So I thought
mm,
it might be a very interesting research topic. And also, I really wanted to help the patients because they were misunderstood, and most of them were, I would say, labeled as a psychological problem or psychiatric disorder. And so this
mm,
kind of really psychiatrizing these patients, where for me, I found this very painful. And so I thought,
yeah,
now we have to find out what's going on and how can we improve the situation. So it's a research project since I would say 94. I had the
yeah.
possibility to work with musicians from 94 because then I moved from the University Hospital of Tübingen in the south of Germany to the Music University in Hannover. And this is a unique institution because it's the only institution where you have a neurological clinic in a music university. So this is just
Mm,
something which is such a wonderful coincidence that I can do the research there to improve the situation of all these musicians.
fantastic. Yeah. So, talking about embouchure dystonia or embouchure dysfunction, broadly speaking, what is embouchure dystonia?
So embouchure dystonia is the loss of motor control of very specialized and skilled movements of the whole embouchure tractus. That means not only lips, but also improving tongue, improving the larynx, and improving even breathing and the diaphragm. So it's a whole system which is somehow
Mm,
not in balance. And embouchure dystonia means, dys means malfunction, and tonus means muscular tension. So there is a
mm,
malfunction of muscular tension of the equilibrium of the balance of muscular functions in the whole embouchure functions, which include these parts of our body.
mm. Okay, yeah. And so, do we know, are there specific causes of dystonia and dysfunction? And
Yeah,
would you say that there's a way to avoid it, or this
yeah.
is ongoing? Yeah.
Oh, that's my heart, my most important topic. Yeah, indeed, we know nowadays we know it's much more before this. So first of all, we have a small subgroup of people which are genetically prone to develop dystonia. Usually they have it in the family. So there is some relative, maybe father or uncle, who has also dystonia. This is a rare subgroup of about 10% of our patients. Then we know now that overuse, that means dysfunctional, too long practicing, repetitive practicing, playing into tiredness, and this might also somehow trigger the development of embouchure dystonia. And then the third part, which is so important, is now the psychological part. We have now found out that about 80% of the musicians developing dystonia later in their life had adverse childhood events or adverse events during their adolescence or during their studies. That means they had some problems with, let's say, divorce of parents, maybe psychiatric disorder of father or mother, maybe dysfunctional teaching situation, that a teacher who was somehow emotionally abusing, and all these kind of things. And this may somehow alter the stress reactivity of the body, so that the musicians become more prone to stress and they cannot cope with the stressors in the profession. And this then is translated into tension of muscle, and this is then somehow stored in the muscle memory. And this may then trigger indeed embouchure dystonia. We have this is one of the parts which is important for prevention. So if you really want to talk about this, it's I think first of all, healthy practice habits are extremely important. Second, and healthy practice habit means breaks. And breaks when, as soon as you realize that you get tired or that you get tense. Then the second part is confidence, so that you can cope with all these stress factors. And the third part, which is so important, variable practice. That means don't, for instance, tonguing practices. Don't do for 20 minutes fast tonguing practices. This might something which is dysfunctional and which is not working. So this is for prevention very important. And then, of course, it's also this kind of, we call it external trigger. So when you practice, in the beginning, of course, sometimes you have to focus on the posture, you have to focus on the larynx, you have to focus on the mask of the embouchure. But usually you should then put an external focus on the sound quality. So listen to yourself. And this will then improve also the motor learning parts. And this is something, I think I have to close the window. We have some constructions here, but so
That's okay.
this external focus is very important also, because this gives you a faster learning rate.
I'm just thinking back. So I suffered from anxiety and panic attacks around the same time as I had an overuse injury, and
Yes.
and you know, I feel like the two were linked, and it's interesting you talking about this one system. It's not just all up here as a brass player or a flute player. It's the whole system. It's every part of your body, which is what you're saying. Maybe you could talk a bit about that. So why is it that so a lot of us in the past, or like you referred to, we've often thought of it as a psychological condition. Can you help us understand like the similarities between the neurology of it and the psychology of so maybe dig a bit deeper into that connection, that physical, mental.
So this all has to do with the impact of stress and stress hormones of our nervous system. So stress is, first of all, it's a normal reaction, and we all have every day some stress factors. But if we have prolonged stress, our brain releases stress hormones, which is, as you know, cortisol. And these stress hormones, they can then, first of all, have direct bodily reactions on muscular tension, on sugar consumption, on excitability of nerve cells. That's one side. but they also have direct consequences for the synapses in the brain. And stress is somehow teaching the brain synapses to link together with the wrong ways. So stress is, we call it a kind of maladaptive reaction of the brain, and the brain learns things which it shouldn't be learned. So the direct link is really via the so-called stress axis, which is somehow changing brain networks, and these brain networks then have a kind of they lose the fine-tuned balance to activate certain muscles in a certain moment in a certain amount. So we have dystonia. It starts with maybe some problem to retract the tongue. When you do tongue, duh, 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 it's easy, but you are stressed, and then the muscles are somehow released not early enough, but they are too late released, and that means duh. So like stuttering, and you have this kind of, we call it the tongue blocking or the tongue stopping. And this then, if you have a susceptible and not a very self-conscious psychological situation, if you are very stressed because the conductor is mean, the colleagues are somehow not under supportive, and you have not slept very well, then this moment, while you have the problem to really control the muscles, will be stored in the memory of your motor system. And this then, if it repeats several times, this storage will become very firm, and the network will somehow consolidate, and you have learned the wrong thing, meaning the tongue must not be moved. So that's the idea behind it. So it's a kind of stress-induced learning which is in the wrong direction. And the way to overcome this is indeed loosen up the whole system, do variable practice, do breathing practice, try to calm down, get the panic, get the whole stress a little bit down, and then you will be able to by and by relearn and overwrite the wrong synaptic connections.
Fantastic. Could you so one really important question that I've been dying to ask you is about pain. So especially with brass players, we find especially in the top lip, a lot of people get pain. Now sometimes it is from so much pressure and it's very muscular, but sometimes it's more of a neurological thing, like just the touching it. Can you tell me, can you kind of talk about pain a little bit?
So pain is very common, and it's, by the way, the most common problem I see. So it's about 60% of my patients come with acute or chronic pain. So we have in our lips, and we have in the mucosa of the inner part of the lips, we have a lot of so-called pain receptors. These are free nerve endings. These free nerve endings are usually wrapped with myelin, so they have a kind of protection sheet of fat around them. But if you play too long, and if you press too much, and if the lip is all the time somehow vibrating, this myelin sheet, this fatty myelin around the free nerve endings, might be somehow deteriorated or degraded. And then your nerve starts to signal pain to your brain stem and to the brain. This is a normal thing which happens, I think, for every musician. And usually, if you then make a rest and you have a break, this myelin will restore and it will build again, and it will be no problems. And the next time you play, you don't feel anything. But if you have to play more, and if you have to continue, and if you then compensate by pressing the mouthpiece a little bit more to the upper lip or the lower lip, then these pain signals will continue, and they will change the synapses from the pain nerves in the brain and make them more effective. That means the pain has the tendency to increase itself. In itself, it's a kind of vicious circuit. And this kind it's called in neurology, it's called the lowering of pain thresholds. So you get more and more sensitive. And now, if you now start to continue and you are afraid and you have anxiety and you get, oh my God, I hope I will be able to play this concert. I need the money and this and this and this.
Yeah.
Then the pain will be somehow stored in your anxiety memory. So this feeling will be linked to a memory, and this memory can be very stable. And then we have the problem of chronic pain. That means that even if the nerves are somehow recovered and the myelin sheet is nice, even then you are more sensitive and you feel the normal pressure as painful. And even some people even tell you, if they hear the sound of your trombone or your French horn, they really feel already the pain here. And this is a classic part of pain memory. And the only way to overcome this is playing without pain. That means start with very low pressure embouchure for a couple of minutes, and then gradually build up the kind of endurance for your lip again.
Yeah, fantastic. What diagnostic criteria form the line between embouchure dysfunction and embouchure dystonia? So I know that one can lead to the other, but so I had overuse,
Yes.
but I know that it wasn't dystonia. But I mean, one of your studies that I read, the one with the great graph of that, it's not so clean cut that it's focal dystonia, but it can be a long journey. But
there's a gray zone.
Yeah, a gray zone. Yeah, but so I'm just asking about the criteria. Like, how do you say, oh, that's definitely this or that?
So for me, a very, very important criteria is if the musician tells me that he is able in the beginning or maybe some days in the week to play a couple of notes without problems. So as long as you have in some register a good feeling and you feel that it is going well, then you have not dystonia. The most important criterion for dystonia, it's always present. And it's present after you start, after a couple of seconds or minutes. And this is something which is the gradual difference. And we call this so-called pre-dystonic syndrome. We call it dynamic stereotype, and that means it's something which is dynamic, that it changes and it can improve a lot also. So if you do proper practicing, if you have psychological support, and if you have self-confidence regained, then you can overcome this. But in dystonia, it's a more lengthy process to recover.
Yeah. That self-confidence thing that you mentioned, one of the big hurdles, is so hard when you've had an injury, when what you do, your identity is taken away from you.
Yeah, exactly.
How do you express to people? How do you give them confidence? I mean, how do you do that? Yeah.
So first of all, I really tell them, even the most severe dystonia, 70% of our clients or our musicians stay in their profession. They might be able, they might need to adjust the repertoire. They might switch from first horn to second horn, something like this, but they stay in their profession. So 2/3 stay in the profession. Second, I also say you have so many other resources. And that's something which is so important, that you also see there is a life without performing. You have students, you have family, you have friends, you have hobbies, you have things other. So I always also draw the vision into the resources. And the third thing is I teach my patients to cope with this very negative emotions which are usually in any overuse and any dystonia. And this, we call it the 4 horsemen of the apocalypse of musicianing. The first one is anger. I worked so hard and it's not functioning. The second one is guilt. I overused myself. I treated it well. The third one is shame. Nobody must know about this. And the fourth one is depression and anxiety. Will I be able to continue? And for the first one, for the for the root, for the first one, this kind of
Anger.
Anger, yeah, genau. Yeah, the stranger. I say it's a experiment of the nature. Even if you are not obviously progressing, your brain is learning subconsciously. It's not lost time. You get some things. There's something changing. You don't realize it. So be patient and see it as a kind of nasty experiment of nature, which you are going now to do research into it. For the second one, for the guilt, it's happening to everybody. It's something, you are not responsible for all these kind of things. There are too many, sometimes too many things to do. There is an overload in your schedule and so on. This is happening. We have to learn to deal with this. Nothing to feel guilty. Shame. In Germany, it's a professional occupational disorder. That means it's really registered in a kind of professional way, and this is, you don't have to be ashamed of it, and all the musicians know about this. So that's the point. And finally, the depression and the anxiety behind it. Think about your resources and think about that 70% stay in their profession.
That's fantastic. Yeah, just going back to your point about when they don't feel like they're making progress, just the fact that the brain is making progress. But as musicians, as you know, we think that progress looks like this. The more we practice, the results we get. But actually, progress looks like steps. You plateau.
Exactly. It's a progress. It's like steps, and even there are sometimes deep, some deeps for this.
Yeah.
And it's fine.
Yeah.
That's a way. And you have, that's something you have to learn, that you need patience. It needs patience, and it needs a kind of also a good, how to say, psychological relationship to your body and to your instrument. So it's very important that you still love your instrument, that it is not linked to frustration and to anger. And it's not easy, I have to say.
No, yeah. So, what approaches do you think have been most successful that you've seen, and maybe your approaches have changed over the years? I'm not sure. But...
Also, my approaches have changed. I think the most successful in embouchure dystonia is now clearly it's retraining. It can be retraining, and there are several ways of retraining. It seems that the retraining has to be individualized. It depends very much on the personality. It depends also on the time frame you have, and it depends also on the way how how sensitive you are, how you treat yourself. So the basis is for me retraining, control of breathing, control of tongue, control of larynx, also control of the lip muscles, reduction of unnecessary tension. So that means awareness of tensions, teach our patients awareness of these kind of things. And the one thing which I developed together with Bronwyn was that we do the retraining first without the instrument, because the instrument is always critical. It's always, you have so many expectancies, you are so critical yourself, and sound quality is not really good, and so you get intimidated by working at the instrument. So that's why we thought it might be good at the basis to learn this kind of movements as Bronwyn teaches, and then finally go to the transition to the mouthpiece, maybe a mouthpiece with a burp, with a pressure device, and then finally go back to the instrument. Retraining is the basis for me. And one thing which is important is we have to have the best conditions for retraining. That means in Germany, we have this wonderful social security. Take a leave from the pressures in the moment. Take a leave of at least 3 months. Better probably 6 months, but take your time. It's now time to care for yourself. And we sometimes also do some additional medications which can improve or speed up the retraining. There are two medications. One is called trihexyphenidyl. It's a medication which works on the basal ganglia in the brain, which somehow makes it easier that the synapses connect in the correct way. So that's
wow.
what we believe. So this is something, but this must be somehow supervised by a neurologist, because it
Yeah.
has also sometimes side effects, dry mouth, nausea and vertigo. And then the
Yeah.
second medication I sometimes use is an antidepressant. It's called escitalopram. It's very common in Germany, and it
I
gives
take
you,
escitalopram, so
yeah, yeah.
tick.
Yeah, that's good, and it gives you just some relief, and it filters out all these ruminating thoughts and all this kind of fruitless sleeplessness, and thinking about this, and that's why I also use. And escitalopram is known nowadays also, and it is supporting the synaptic regrowth and supporting beneficial nerve plasticity.
Yeah, because it's even though it's an antidepressant, it's also used to treat anxiety, which for me it's
Exactly.
treat anxiety.
Exactly.
So yeah,
It's
oh,
it's
fascinating.
also
Yeah,
used.
yeah,
It's used for treating anxiety and also the constraints. And many of my
yeah,
musicians have a lot of constraints. I must practice, and if I don't practice for
yeah,
hours, I'm not a human anymore.
yeah, yeah. So conversely, are there pharmaceuticals that are detrimental to
Yeah,
embouchure dystonia?
yeah.
Oh,
I
yeah,
just closed the window. It's there's some chainsaw. Okay.
yeah, sure.
Yeah. So, okay. Yes, there are some pharmacies which are detrimental. So the first one I really warn you is alcohol, too much alcohol consumption.
Mm,
Many musicians start because alcohol has an antidepressant effect, and alcohol
mm,
has also can release a little bit the muscle tone. And alcohol also can somehow, it blurs your perception of your own sound, and so you feel that you are somehow better as you are. And alcohol, of course, makes you addicted. So this is something which is detrimental.
mm,
Another thing which is also detrimental is all kinds of benzodiazepines. These are medications which are usually used for anxiety.
mm,
They are good for short-term panic attacks. So
mm,
this one is called alprazolam. That's okay for panic attacks, but don't use it on a regular basis. You will become addicted, and this
mm,
means you have less freedom, and you have a negative self-concept. If I'm an
yeah,
addicted person, I
yeah,
feel guilty about this. And then I think the other medications I sometimes take additionally, especially if there's a lot of trembling and tremor in embouchure. Like
mm, yeah,
sometimes give a small dosage of so-called beta blockers. They reduce the muscular activity, and they can be very beneficial for trembling, and
yeah,
they don't enter the brain, so there is no danger of a bodily dependency. However, sometimes you have to discuss this with your clients. Sometimes they make you psychologically dependent. So the beta blockers, they are not they are not dangerous. They don't harm you, but you have to discuss it with the patient, that they just give you a kind of, they open the door that you can have access to the own resources and your own abilities you have learned during 20 years of training.
mm. Yeah, yeah. I mean, a study that Bronwyn did in Australia, we know that 40%, 50% of musicians, professional musicians, take beta blockers
Yeah,
for
yeah,
performing.
yeah, yeah.
So
I mean, most of them do it without
very
prescription.
well known.
I
Yeah.
sometimes, yesterday I prescribed, for instance, a beta blocking for young students, and she had
Mm,
a bowing tremor, and she
mm,
was so panicking, and I said, you take this for the next auditions, and then if it's going well, we talk about this, and you reduce it then
yeah,
systematically. So you have to
yeah,
guide the patients.
yeah, yeah. So the Embouchure project, which is this this kind of organization we're trying to put together, we're working on the premise that as a musician, if you have an injury, it's not just to go to a teacher or to a doctor, but I think you need that to check that checklist, a neurologist, psychologist, physical therapist, to really recover. Would you
Yeah.
agree that this kind of approach
Yes.
is needed? Yeah,
I
it
think
sounds like from what.
it's extremely good. So I usually say you should see, if you have an embouchure problem, you should see once in your life. You should see a neurologist, because
Mm,
there are some other rare disorders, especially in
mm,
the elderly. For instance, Parkinson's syndrome may mimic embouchure dystonia. We have some patients who had problems in control, and I saw already they had also a little bit shaking in their fingers, and they
mm,
had some changes in the sleep behavior and so on. And so this was the first sign of Parkinson. So I think with embouchure dystonia, it's so important for you. You should check once with a neurologist.
mm. No, that's great. Um, what do you think? What studies do you think remain to be completed in this
Yeah.
field?
I think it's still we can still optimize retraining, and what we need is to get better predictors which kind of retraining is functioning in which person. So we need a kind of client-tailored prediction system. So if somebody has
Mm,
a kind of a lip pull like this in an embouchure, this must be retrained in a different way as somebody who has a tongue stopper, who cannot move the
mm,
tongue anymore like this. So we need to have a better, I would say, learning and relearning approach. And this is what Bronwyn and myself are working on it. So we want to have this client tailored. The second thing I think which remains also is, of course, still what you're doing is great. Still inform the public, inform the musicians
mm.
about it,
Yeah.
and inform that at the right time without producing anxieties. Just tell me
Mm,
there is a problem which can happen. There are people who really know how to react, and but be sensitive and try to adopt healthy practice habits. Try to think about your self-confidence and so on. So I think there is still in the culture of the musicians there needs to be something done, and seems to that information needs to be spreaded. And then finally, the third one is, of course, how we can better influence this anxiety problem, and how we can better influence all this kind of also performance anxiety. We have
mm,
so many courses, and we have so many specialists, and there's all these coaches and teachers and so on doing performance anxiety, and still many musicians never can somehow get rid of it. And
mm,
I think we need to better understand this.
mm. Yeah, that's fascinating. So, so if there's one thing that you wish all healthy wind players knew, what would that be? Like, what would your main thing be?
I think the best prevention is stay happy with sound and with music.
Mm,
Love your
mm,
profession. I think that's the most important part. If you love your profession really, and if you do it because it's for the love of music, you will find the ways to behave in a healthy way, and you will.
mm.
I think that's the most important part. Love of music.
Yeah, because not every musician does, if we're honest.
No, no, I
Yeah,
know this.
yeah,
I know many. They get bored, and in the
yeah.
German orchestras, we have a
Mm,
lot of people who get somehow they get bored. Yeah, that
mm, mm.
you need to keep this love alive. The love
Yeah.
for music, keep it alive. And one way to do is, of course, chamber music. One way is teach young people, show your instruments, the beauty of your instrument to other people. So there are many ways to improve this kind if you have a kind of burnout in the orchestra.
Mm, mm. So you've been doing all this important work since the 80s, the 90s. What do you wish you knew back then that you do now?
I think the first of all, if I think the first misdiagnosed patient, I I I simply I think the whole work on dystonia, uh, I would have wished to have this known in the 80s or in the
Mm,
85s. I remember one of the friends of my family was a famous cellist, and he had a terrible dystonia, and nobody ever believed him. He couldn't play
mm,
anymore. And I remember that was in the 70s. And I
mm,
think if I had known about this, a lot of people could have spared a lot of suffering. I have to say that they found other ways. As you know, the case of Robert Schumann, the composer, who was a pianist with a dystonia of his middle finger. And fortunately, he found this way of expressing his musicality by composing. So we have now one of the greatest composers of the Romantic period.
Yeah, and that ties into what you said. It's so important to identify your identity, not only as your instrument. You're not just a piano player. You're a father. You have other interests, and and when you're confronted with an injury, you have to sit down and ask yourself that question. It's like, okay, I might not play again, and
exactly.
It's great to hear you talk about all this. Well, I wanted to thank you so much for your time. I know you're a busy man, and
I want to thank you for your work. As I told you, I think it's important to inform people about this.
To talk about, because as musicians, we go around, polishing ourselves and saying how good we are and but when something's wrong, you don't want to give away that you've got a weakness, and fantastic. Thank you so much.
Okay, thank you, Frankie, and have a good time. And I would like to, if you need something or if you need more contributions, I'm happy to help you.
Thank you so much. Cheers.
Okay, ciao, goodbye.
Thanks for listening to this episode of the Embouchure Project podcast with me, Frankie Lacerda. The strength of this project is our network, so please go to theembouchureproject.org to sign up for our mailing list, follow us on Instagram, and join our group on Facebook. If you have any questions, please don't hesitate to email us at info@theembouchureproject.org. We look forward to hearing from you.